So here at Kalen West, my name is Richelle. I am the founder of Kalen West and the lead practitioner, physician assistant, certified, meaning I'm board certified, independent, meaning I can practice without a physician oversight here in the state of Oklahoma. And if you landed here today, we're going to talk a little bit about lab reference ranges when it comes to hormones, because you can go get your hormones checked at a primary care office, maybe your OBGYN, and they're going to spit out some levels and say, oh, that looks normal. Or tell you, looks like you're ovulating, looks like you're in perimenopause, looks like you're menopausal if you're female. Or if you're male, it might say, hey, it looks like you got enough testosterone, you're kind of on the low end of normal. But what does that really mean? Now, I didn't know this until I started working for the great and late Dr. Meehan, and he brought me up to speed with the evolutionary trends of what we call reference ranges when it comes to labs. Now, it does vary lab to lab because some labs measure different metabolites of hormones. But overall, what he taught me was when you're looking at the population data sets from the 70s, 80s, 90s, we will see a decreasing trend in what the standard reference range was for, quote, normal. Now, you should know different labs measure different metabolites when it comes to hormones. For example, Quest versus LabCorp will have different reference ranges. And so it's important. You can't quite compare apple to orange. And so whenever somebody enters a Kalen West consultation, we use primarily LabCorp for the backbone of our assessment, our therapies, our treatments, and our guidance. We can interpret Quest too, but it is important to know that what you're bringing into us or what we may obtain for you will have to be interpreted differently based upon the lab that is looking at your hormones. So that's just a little caveat. However, so back to lab reference normal. What's normal? Well, one, it's going to depend on the lab company that you're using, just like I said. But then two, with this whole evolutionary trend, if you look at what was normal maybe back a few decades to what's normal now, it's actually declined. And we are what you would call sicker generation, or perhaps a more environmentally influenced generation with toxic waste, toxic products, things called xenoestrogens that mimic our hormones and sit on receptors, but that then don't allow our body to process what we naturally make on our own. And so by default, and kind of by the mess of the world that we live in, not to give it discredit to the beauty of the world we live in, but by a lot of the commercial products that we have available to us in this day and age, our reference ranges have been impacted in a negative way. And so when someone comes in, one of the conversations that we have from the beginning is, hey, we are using LabCorp hormones, just FYI. And as you look at these reference ranges, don't freak out, because high might not really be high and low may not be really low. And so I always like to set the stage, letting them know that also, by the way, the aggregate of this data and where those reference normals are coming from is primarily from people who are sick in the ER, who have a hospital stay, who are, at the primary care with the flu. It's not just wellness checks. A lot of the influence of the standard aggregation of these reference ranges comes from what we call a sick care population data set, not an optimal wellness, longevity, and happy and health kind of population. So the reference ranges we take into consideration, but also with a grain of salt when it comes to hormone therapy and what we're looking for. So for example, I'm going to talk about a postmenopausal female here. We are going to be looking at your pituitary hormones, so something called your LH and your FSH, to kind of gauge where you are if you don't know if you're in perimenopause versus menopause. Your FSH will trend upwards. It is responsible for thermostating and talking with your estradiol downstairs. If you have a lot of estradiol, your FSH should be low. It's an inverse relationship because your pituitary gland will accurately sense that you're well fed with enough estradiol hormone. And if you have enough estradiol, then the pituitary gland doesn't need to work as hard to chug out the FSH hormone, which is the signal for estradiol to grow. Okay, kind of a simplistic term. So we'll check a postmenopausal female, an LH and an FSH, and we're looking for something like this. When you are ovulating, your FSH would be somewhere between 5 and 7. And I might have MIU per milliliter, okay, a little cheat sheet, because I want to be correct on reference units. So your FSH would be between 5 and 7. Now, your LH would be somewhere between 7 and 10. LH responds to how well fed you are with testosterone. So in a normal ovulating female, I'm looking for that type of pattern, and generally speaking, your FSH is twice as great as the LH. If it's in a flip, that's a clue that you may have some PCOS, which is now called something different. But that is a clue for us as to kind of where are you in your hormonal evolution as a female. Side note, postmenopausal females, most of them have an FSH of 50 or greater, along with an estradiol less than 30, and obviously the cessation of menstruation. But those are why we track some of those hormones. It's just a little clue as to what we're looking at and why, and reference ranges associated with such. Now, if your LH is high, it could be because we have PCOS going on if you're ovulating female, but if your LH is high and you have a low testosterone, that shows us that those two things are sensing each other correctly, because again, the lower hormone you have downstairs, the more signal your brain is going to put out to your body to make it. And so we correlate those two things and look at, everything else involved. But reference range assessment purposes, what we're looking for normal for an ovulating female would be somewhere between 5 and 7 on FSH female, and somewhere between 7 to 10. Not in your ovulation window, caveat on that, because LH peaks and surges in ovulation, but just to give you an idea of what we're looking for and why we order these things, if you're in perimenopause, that FSH is going to start to creep up and up. It might be 25, 32, till it hits that 50 mark and above. Menopause, you usually should be at 50 or above, but caveat, pituitary hormones sometimes lie. If you've had trauma, like blunt shear force to the brain, like a concussion, a motor vehicle accident, you played lacrosse and got hit all the time, or if you're a football player on the male side, or if you were female and you had postpartum hemorrhaging so severely that you need a blood transfusion, there's something called Sheehan syndrome, which can stunt your pituitary hormones. So anyways, this is why you need to work with a provider who knows some of those things. But for example, when we're talking about lab reference ranges, FSH and LH is something that we lock in on to look at and see where are you in your pre, peri, postmenopause journey, and or fertility purposes if you're female, male. I haven't talked about the male FSH and LH. We won't right now. But just to give you an idea, that's one example of a reference range assessment that we look at that can help guide us clinically, diagnostically, and then help us sleuth into what's the appropriate treatment for you moving forward. So reference ranges can be tricky. It depends on the lab that you're using. It depends on the data set that you're looking at in terms of, are you menopause, premenopause, or postmenopause, or andropause if you're a male, or normal if you're just a male. There's no real term for unaged male, young male. We'll just say young, healthy male. Anyways, I digress. But FSH and LH is something that we like to talk about.